Continue our lecture in gynecology, anomalis, uterine bleeding. Reproductive health of person in vital use. It is known regular uterine bleeding is the basic sign on synchronous work of reproductive system. Normal menstrual bleeding is defined as cycle menstruation every 21 to 35 days that lasts fewer than 8 days with 20 to 80 milliliters of blood loss per day. For practical purpose and any patient who complains of a change in her previously established menstrual pattern may be considered to have abnormal uterine bleeding. This slide you look new classification, anomalis, uterine bleeding. Divided, organic and functional. Name, palm, column. From first object, polyps, adenomyos, glioma, malignancy or hyperplasia. And non-organic, coagulopathy, ovulatory, endometrial, iatrogenic and not yet declassification. Repeat, new name this classification, palm, colon. Definition. Primary amenorrhea refers to the absence of menstrual by age 15. Secondary amenorrhea refers to absence of the menses for 6 months after established menses. Hypomenorrhea is poor uterine bleeding. Hypermenorrhea is plentiful uterine bleeding, more than 100 milliliters per day. Oligomenorrhea is uterine bleeding that lasts less than 1-2 days. Opsomenorrhea is uterine bleeding at intervals of more than 35 days. Polymenorrhea is uterine bleeding that lasts more than 8 days. Promenorrhea is uterine bleeding at intervals of less than 21 days. Menorrhagia, hyperprolaminorrhea in excessive bleeding at regular intervals. Metorrhagia is bleeding at irregular intervals. Menometorrhagia is severe irregular bleeding. Dysmenorrhea is painful menstruation. Diagnostic of disorders menstrual function. Physical examination, anamnesis, general examination, examination study with herpes speculum, vaginal internal examination and rectal abdominal examination, bimanual combined abdominal examination, laboratory examination, cytological investigation, microbiological investigation, level of hormones, follicle stimulation hormone, luteinizing hormone, prolactin, estradiol, progesterone, cortisol, testosterone, dehydroepiandrosterone in the blood. Additional special method examination, diagnostic hormone test, test of functional diagnostic, basal temperature, colpocytology, cervix mucus tension, Fern symptom, papil symptom. Ultrasonic examination, karyotype, X-ray examination, hysteroscopy, uterus diagnostic, curettage, uterus diagnostic laparoscopy. Causes of anomalous uterine bleeding, stress, psychological, physiological overstaying, elementary infections, somatic diseases, inflammatory, acute and chronic infection, endocrine diseases. The diagnosis of anomalous uterine bleeding is associated when an organic cause can be found. Result of this abnormalities of function is a hormone dysfunction of ovaries. Looks like the endocrine system is full. How this regulation of full endocrine organs? View of anomalous uterine bleeding, ovulatory, anovulatory with atresia of persist of follicle. View of ovulation, anomalous bleeding, hyperfunction of corpus luteum, a persist corpus luteum that does not regress on the 12-14 days may result. Hypofunction of corpus luteum, regress of corpus luteum rather than 12-14 days. Hypofunction of follicle. View of anovulation, pubertal, reproductive, perimenopause. Pathogenic of anomalous bleeding. The level follicle-stimulating hormone increases. After this level, luteinizing hormone increases. This follows on ovulation, decrease of the level of progesterone, hypoprogesteronemia, absolute or comparative hyperestrogenemia. Necrosis appears in hyperplastic endometrium. The endometrium eventually breaks down. Pubertal frequency pubertal is 10%. The process of follicle atresia often takes place of various. Clinical manifestation is absence of menstruation, 1.5 months at bleeding. Frequency reproductive bleeding, uterine bleeding is 4-5%. The process short-term persistence of follicle often takes place in ovaries. Hyperplasia of endometrium reproductive period is more expressed than endometrium hyperplasia of pubertal period. Perimenopause frequency is 50%. The process prolonged and persist of follicle often takes place in ovaries. A change of hypothalamus decrease rhythm of quantity of hormones, age decrease receptors contrapine of ovaries. The result of these abnormalities of function hormonal dysfunction of ovaries. The result of an evolution comparative of absolute hyperestrogenemia. Hyperestrogenemia is the cause of endometrial hyperplasia. Necrosis appears in hyperplasia endometrium. In the absence of progesterone, the endometrium will break down. Clinical manifestation prolonged uterine bleeding during 6-8 weeks and more. Diagnostic physical examination. The patient should firstly electric throughout stable hemodynamic. Patient does not require immediate restrictive intervention. Attention should be directed to abdominal and pelvis. Examination of the abdomen can determine if the patient has an acute or surgical abdomen that requires urgent surgical intervention. Inspection of the vaginal wall can demonstrate a degree of current bleeding, the chest secretive infection, or evidence of trauma, lesions, polyps, tissue, and masses. Abdominal examination should be performed to establish the states of internal size and control of uterus and adnexa. Laboratory studies. The patient hemoglobin level, hematocrit, proton beam time should be determined. Any patient of childhood age must be assumed to be pregnant until proven otherwise. Therefore, a urine level of human chronic contrapine disturbance, chronic contrapine must be obtained. A pap smear if patient's not activity bleeding to ovulate for cervical neoplasia. Ultrasonography is useful to evaluate for the presence of benign reproductive tract conjugation, such as fibroids, possible polyps, intrauterine pregnancy, and ectopic pregnancy. Sonography involves the installation of isolation into the uterine canal during ultrasonography. Sonography is the most sensitive method of diagnosis of endometrial polyps into submucous myoma. Office hysteroscopy and biopsy. Hysteroscopy can be used to visualize the endometrial cavity, directly to look pathology, and to perform a direct biopsy. Uterus diagnostic curettage with cytology. Treatment of pubertal uterine bleeding consists of the first stage is stopping bleeding, the second stage is normalization menstrual cycle. During this first stage apply uterotonic intravenously dropping oxytocin, 5 united hematocrit treatment, tranexan acid, combined menopause estrogen gestagen hormones. Treatment for anemia, tetema, ferroplex. In blood analysis gives the hemoglobin lower 75 grams per liter, hematocrit lower than 20%, or hormonal hemostasis wasn't effective, follows a surgical hemostasis. During the second stage, the cycle treatment apply combined menopause estrogen hormones therapy. Treatment of dysfunction during bleeding reproductive period. First stage is stop of bleeding, second normalization menstrual cycle. Surgical intervention indicated in blood loss cannot be replaced with the transfusion of bleeding. During the first stage, may able hemostasis with high dose hormones if you know the histology of endometrium. During second stage, cycle treatment therapy. Treatment anomalis uterine bleeding perimenopause period. First stage stop bleeding. Second stage sufficient the function of ovaries. Surgical intervention indicated in blood loss cannot be replaced with transfusion or bleeding shoes gas obtained after 40 hours. Dilation and curative cytology should be followed by hormonal therapy. For dysfunctional uterine bleeding of perimenopause period necessary to press the function of ovaries, hypergestagen, undergone therapy in hormones, releasing hormone agonists, androgens in virile regime during 6-8 months. Gestagen dufaston pravera depo pravera. Andestrogen hormones, nimistran, undergone therapy in ganazole. Therapy releasing hormones ladex, glycerylin, decapityltriptorelin. Androgen, sustanon, amandron. Thank you for your attention.